This is now the continuation of Fundamentals of Nursing 2, KRCHN, that is Community Register Community Health, Kenya Register Community Health Nursing 1.2 under the Adult Nursing Continuation. Now previously we already tackled a greater deal of the same. This is just about the remaining part which we were supposed to proceed by today and maybe see on our conclusion together. What we're going to study here is simple, and from your hand I'm very sure that you are able to view the screen. Now last thing we did is that we talked about the mechanism of respiration, and the respiratory rate center in the brainstem said it's being controlled by the respiratory is being controlled by the medulla and the component of the brainstem, and this rate is also influential to the breathing and even how your heart pumps. So this is stimulated by an increase in acidity of the blood. I want to give you a clue about this. Your blood is always composed of either oxygen or carbon dioxide. When you are breathing in a low pace, or maybe when you have dyspnea, difficulty in breathing, that is, you end up having very less oxygen, but instead carbon dioxide pile up and concentrate in your blood. So this one normally comes about, and if that happens, remember the carbon dioxide is always acidic in nature. That is, if you take carbon dioxide then you react it with water, it will give you weak carbonic acid. So the same applies here. So when we don't breathe, or when we have difficulty in breathing, the carbon dioxide will increase, and therefore the acidity of blood will increase. When this blood passes over in the brainstem, the pH will be detected, and therefore there will be stimulation of breathing receptors, and all this one will trigger an increase in respiratory rate. Movement of air in and out of the lungs comprise the respiratory cycle, and the cycle said it occurs about 15 times in a minute, and it consists of inspiration and expiration and the pause. So there is where we talk about some of the anticipated measures that give us always knowledge about how effective is our respiratory cycle. And we talk about the following volume. We have tidal volume. That is also important to know because it's supposed to be at a normal rate of 500 mils. The amount of air that comes into out and into and out of the lungs with each cycle of respiration. That is tidal volume. So this one all already covered in the previous work about the expiratory reserve volume, inspiratory reserve volume, residual volume, forced expiratory rate. So you really need to know them. Therefore, this one also helps us to evaluate if somebody is suffering from a chronic disease which affects the respiratory rate, like tuberculosis. If somebody has got he has got cancers of lungs. When another case, strong asthmatic person, let's say that is the asthmatic status is high. So we'll get to know how this one has entirely affected the respiratory system. Vital capacity was the next thing, and the vital capacity is very key. So the vital capacity is the amount of air that can be forcibly expired after forcible inspiration, and this means that after you force yourself to take in or inhale oxygen, what you give out forcefully again is what we call the vital capacity. So this varies with the size of the thoracic capacity. It's also made up of the tidal volume, inspiratory reserve volume, and expiratory reserve volume. So to mean you can add tidal volume, inspiratory reserve volume, and expiratory reserve volume to get the vital capacity. So that is a measurement what is always used in the lab for our, in the hospital for our clinical investigations. So we can measure off the quantity in a normal aspect and then figure out if yours is normal. So let's have on general clinical features of patients suffering from respiratory conditions. 1. These are the what the patient will present with when they come to your clinical bench. 1 is the cough, which is very common from irritation of the respiratory mucosa, and then the cough reflex protects the patient from accumulation of secretions and irritant substances. So what you see here is that cough is just a typical reflex which helps the patient to get rid of the mucus which may be accumulated due to a condition or infection or maybe a sort of disorder. So it's a reflex which will help in clearing the throat way. And so cough comes as much of those mucus irritating your respiratory mucosa. So therefore cough may arise from inflammation, exudation or secretion, or irritation by foreign materials or irritants. The irritants are like the spray, the mucosal spray, like the nasal spray, A cough may be described as dry, brassy, high-pitched, wheezy, heckling, loose, or severe. So when you are taking history, don't forget to ask, do you have a dry cough, irritative cough, breathing away? Does it grab you or maybe brush over your mucus? Is it high-pitched? Does it produce a very high tone? Is it somehow wheezy, obstructed with a wheezing way or wheezing sound? And so on and so forth. Another feature is sputum or sputum. This results from overproduction secretion, which may result from the inflammatory processes. Sputum is examined for consistency and color. Another one is chest pain. Chest pain is always associated with pathological process in the affected area. However, note the lung and viscera have no sensory nerve ending and are unlikely to produce much pain except when parietal pleural is affected. There is no sensory nerve ending in the lung region. So God was very smart because he knew a lot of activities are happening on the lobula of the lungs, and so by that you end up having pain every frequent. So this guy removed the sensory nerves on your lungs and the parietal region. So at most it's unlikely to produce much pain except when parietal pleural is affected. So it produces sharp pain called pleuric pain. That is only when parietal pleural is affected. Another condition is wheezing. Another clinical feature is wheezing. Yeah. And on wheezing, what is important about wheezing? When you talk about wheezing, you have to know it is something related to something like a constriction, sort of, when somebody inhaled air or maybe oxygen. So it is associated with the bronchospasm. Bronchospasm means that the bronchus is narrowed and constriction of the airway. So it is usually had without the help of stethoscope and usually on expiration when this person is ejecting or removing oxygen. Hemoptysis. Hemoptysis, this is just blood, either coughing blood, sort of. Blood may be expectorated with the sputum, and this ranges from the blood stain to hemorrhage. So it is usually associated with bronchitis. Somebody with the condition of bronchitis, that's inflammation of the bronchus, or pulmonary tuberculosis or bronchial asthma. Pulmonary tuberculosis is a TB that affects the lungs and the respiratory region. And then the bronchial asthma is a kind of asthma due to bronchospasm of the bronchioles. And carcinoma of the lung, that is a cancer, typical benign cancer that affects the lungs. And then pulmonary embolism, that is when a clot is formed in one of the pulmonary vessels and infarction occurs. Clubbing of fingers is another one. It results from hypoxic lung disease like malignancy or bronchiectasis. And clubbing of fingers is just that tendency of the diamond shape, which is between your two fingers, and you club on the nails. That diamond shape disappears. It's supposed to be at 180 degrees, but when it disappears, that is called finger clubbing. Therefore, your nail will be a tendency that the basement of the nail is not going to be figured out clean. So these are normally due to hypoxic lung disease like malignancy. When I say hypoxic, these are conditions in the lung that defile the lungs from adequate oxygen. Therefore, there is that tendency of anemic symptoms or syndrome. Cyanosis is another case which can also present when a respiratory system is interrupted. It appears when circulating hemoglobin carries less oxygen than 2/3 of the expected amount. So it can be either central or peripheral. But what is this? Cyanosis is just the bluish of the body mucosal part, can be of the extreme fingers. When you talk about peripheral, those are your limbs, right? But when we talk about central, is just on the frenulum of your tongue and on your lips. That is the bluishness of that. Dyspnea, the difficulty in breathing, can also come as a clinical manifestation, and this is a labored or breathing is increased lung rigidity and airway resistance. So dyspnea may lead to tachypnea. Tachypnea, when you have difficulty in breathing, you'll have tachypnea, to mean that you tend to breathe faster. So when somebody presents with a high tendency of that breathing rate is increased, they are talk about this person struggling to breathe. But by struggling to breathe, you end up having tachypnea, like breathing faster, because even breathing at all becomes a problem. Mechanism of breathing is another thing that we need to know, and here you need to know that there are chemoreceptors in the walls of the outer and the carotid arteries, which sense the changes in the partial pressures of oxygen and carbon dioxide, and this will determine the rate of breathing. For example, now while you are seated reading, you breathe quietly. However, if you stop breathing and start doing some exercise, the breathing will become faster and deeper in response to the need for more oxygen and to get rid of carbon dioxide. Following, you need to know that is just a bad example. You can do it when you take a deep breath and make a mental note of how your ribs and diaphragm move while you are breathing quietly, using your intercostal muscles and diaphragm in different breathing systems such as the abdominal muscles may be used. Now, when you have dyspnea, what I'm trying to say is simple. When you have dyspnea, difficulty in breathing, your normal breathing pattern will change. You'll now be forced to use even your other muscles, the accessory muscle, like the sternocleidomastoid muscles. You can also have the abdominis, rectus abdominis muscles helping over so that you can enable the lungs to move for you to breathe. Following a phrenic nerve stimulation. Phrenic nerve is a nerve which is found in the diaphragm. So the diaphragm and the respiratory muscles will start to contract. Then the thoracic cavity increases, the lungs follow the move and then begin to expand. Air will rush from positive pressure outside to negative pressure in the lungs. And that inspiration is complete and expiration starts with the reverse of the process. We have control of respirations like alveolar stretch receptors in the wall. The lungs send a message to the brain to prevent over distension of the lungs, so it will control it. Blood pH stimulates the respiratory center that I told you before that partial concentration of carbon dioxide and partial concentration stimulate receptor to control the rate of breathing. In the body tissues, gas exchange occurs by diffusion from high concentration to low concentration. Oxygen binds to hemoglobin to be transported to tissues for use in producing energy. You now look at the disorders affecting the respiratory function as well. So let's now have that one on check. Now, these are diseases that affect the upper respiratory tract. Start with the upper respiratory tract disorders. Many of the patients you have been nursing may have been suffering from upper respiratory tract infection. Others may also have an inflammation, trauma, or tumors. Trauma ni kuumia, tumor ni cancer. Inflammation ni maradhi ambayo yanaletwa na asili ya mwili yako kureact zaidi due to hypersensitivity and so on and so forth, so that's like an allergic form. So another common disorder, especially among young people, is epistaxis, that is nose bleeding. This is the nose bleeding. The most common cause of epistaxis are trauma, infection, tumors, and high blood pressure. So normally foreign objects inserted accidentally can cause airway obstruction, which you should treat as an emergency as well. And you'll start by learning by respiratory infection. When I say foreign objects you can't find in your casualty or triage, somebody is having difficulty in breathing and so on, there's a clot or maybe a blockage on the airway by any material, you will really start by ABC triage, the primary surveillance ABC. So you'll check on the airway, breathing, circulation, and you know how to find on the airway. Call the patient, immediately he speaks, that is done, airway is clean. Breathing, check on the nose, there is nostril movement, that breathing is confirmed. Circulation, you can check on peripheral, peripheral the peripheral circulation, you see on that. Now that is that. Now on the upper respiratory tract infection, let's have that. We want to detail each of them. So the upper respiratory tract often falls victim to viral infection, and the most common viral infection are the pharyngitis, tracheitis, tonsillitis, laryngotracheobronchitis. Those are combination of the pharynx on the laryngeal being infected, the tracheas being infected, bronchitis being infected, and then the influenza. So all these are the main customers of which are caused the viral infections, and that is very important to attribute. So viral infections cause inflammation, resulting in congestion and watery exudate formation, and in adults these conditions do not cause very serious illness unless the individual's immunity is compromised. The management of infection involves use of antibiotic, control of fever, and relief of discomfort. That is, you have to use antibiotics to kill the bacteria, if at all, or the virals, the strains. Then you have to control fever by giving antipyretics, or maybe using the cold pack, the warm pack, at most for babies, and relief for discomfort by reducing the pain, that is using the analgesic. So the nose is part of the respiratory system, and the nasal polyps can affect it. These are small masses that protrude into the cavity, called them the nasal polyps. So their cause is not clear, but chronic inflammation is thought to be a risk factor. Allergic rhinitis is commonly associated with allergens such as pollen, animals, fur, and dust. Patients are frequently sneezing, running nose, and nasal blockage. Proceeding on the same, we have still acute sinusity. You know, in your facial bones, we have cavities or spaces within your, the frontal bone, the sphenoid bone, the nasal bone. These spaces are called sinus. They always house for hair and some sinus fluid. So acute sinusity is an inflammation of the sinuses. Mostly when you have a flu and you feel like you just need to slap your forehead. That is what normally has you in control. So the microorganisms that spread from the adjacent nose and pharynx commonly bring about the inflammation, and there follows congestion blocking the drainage from the structures. This results in the dull pain of the affected sinus. Fever and sometimes purulent discharge. If there is communication with the nasal passage, sinusity can become chronic if not well managed. And let's talk about the acute pharyngitis. A company is common cold mostly. So the acute pharyngitis is infection caused by, the infection causes inflammation resulting in congestion of the nose, and the infection can spread to the nose and the sinuses as well. Laryngitis and bronchitis are the other infections that affect the upper respiratory tract, mostly due to trauma, foreign bodies, or infection as well. So the trachea may be accessed via an endotracheal tube. This is inserted to open an airway for emergency resuscitation or to deliver anesthetic gases. Tonsillitis is another common inflammation, and it affects the tonsils, and it can be acute or chronic. Streptococcus pyogenes and some viruses commonly cause the inflammation of the tonsils. Other microorganisms that can affect the tonsils are like staphylococci, Haemophilus, influenza, and also tumors are rare in the upper respiratory tract. Care of adults with upper respiratory tract. Let's talk with how we can take and manage conditions of the upper respiratory tract from the adults. Starting with the epistaxis, they are telling the bleeding on the nose. So the most common causes in the nosebleed include the trauma, especially picking of the nose. When you are fond of using your long nails to prick the nose, or maybe a stick or the toothpick or whatever. So infection can also be there. Tumors, that is cancer, high blood pressure when somebody is under control of the. So if a patient presents with this, always consider inquiring about the history of any nose picking, infection, tumors, or if the patient is a chronic hypertensive patient. Bleeding is caused by the rupture of the tiny blood vessels on the mucous membrane, and it may also occur as a sign of rheumatic fever. Rheumatic fever is a cardiovascular condition due to defected connective tissue of the heart. Normally it presents with the high fever, and the major and the minor Jones criteria can help you to diagnose it. Let's talk about the management. For a patient with epistaxis, which manifests quite often in our community, simply first aid means may be effective in stopping the bleeding. It is important to keep the patient quiet. Place them in a sitting position, leaning forwards or reclining with the head and shoulders elevated. You can apply pressure by pinching the lower portion of the nose for 10 to 15 minutes and apply ice if it is available to try and stop the bleeding. Partially insert small gauze and call for more help. If first aid is not effective, management involves application of vasoconstrictive agents. So find the drugs which are called the vasoconstrictive agent, the opposite of the vasodilators. Or you can use cauterization. If after packing the patients require oxygen, then it should be given. Mouth care and antibiotics will decrease the possibility of toxic shock syndrome. Away from that, let's have rhinitis. Rhinitis is the inflammation of the mucous membrane of the nose. It can be as a result of infection or allergic reaction. So when the cause is allergy, it refers to the allergic rhinitis. Rhinitis can be caused by infection, but I just want you to know there are more than one type of rhinitis. We have the allergic rhinitis, we have the chronic rhinitis, etc., acute rhinitis, so it depends. So it can be caused by infection that could be bacterial or viral, and the most common being viral. Rhinitis causes inflammation of the nasal mucosa, leading it to become congested, swollen, and edematous. This leads to an increase in the nasal discharge, and in cases of bacterial infection, this could be a thick nasal discharge. This is then referred to as the acute rhinitis. Recovery may fall after a few days. So repeated attack lead to deposition of abnormally large connective tissues in the nasal mucosa membrane, leading to thickening and hypertrophy. So this causes formation of spurs and polyps in the nasal the septum, and there could be excessive exudation leading to atrophic rhinitis. Patients present with frequently sneezing, running nose, pleural discharge, and nasal blockage is another condition. So let's start with the pharyngitis. This is the inflammation of the pharynx, which commonly accompanies the common cold. It is caused by several viruses and bacteria. So the throat becomes inflamed, leading to the mucous membrane becoming fiery red. The lymphoid tissue, including the tonsils, becomes swollen with exudates. A complicated pharyngitis resolved in 3 to 5 days, while complicated pharyngitis may cause other otitis media, that is infection on the inner ear, sinusity, mastoiditis, that inflammation of the mastoid, rheumatic fever, and nephritis and adenitis, swelling of adenoids. Management of pharyngitis is another thing which is important. For uncomplicated pharyngitis, a lot of fluids are recommended with saline, antimicrobial, antifungal lagagos, intravenous fluid recommended if one is not able to take them orally. Liquid diet is given due to discomfort in swallowing. Bacterial infection are treated with antibiotics. Staphylococcus and streptococcus infection is treated with penicillins. Another condition is laryngitis. These affect the larynx, the voice box. It may be caused by the use of irritant, abuse in the use of voice. Ukiongea mingi. No, not like Sauma. So let's have away from that. So it can also be due to infection. So the bacterial infections are usually secondary to viral infection. The causes include exposure to low temperatures, malnutrition, low immunity, and dietary deficiency. Laryngitis presents with a hoarseness or complete loss of voice. The complete loss of voice is what we call the aphonia. So severe cough and general malaise can also present. And the management of laryngitis include irritants like tobacco, smoking must be avoided. Steam inhalation or aerosol therapy is important to soothe the mucous membrane and facilitate drainage of mucus secretion. Antibacterial therapy is done where bacterial infection have been suspected, and the rest of voice promotes healing. This is done in a well-humidified environment as well. Rest of the voice promotes healing, that is, you are resting the voice, you don't use it. Plenty of fluid must be given to replace loss of fluids and to thin the secretion, and steroids could be beneficially in reducing inflammation as well. Another condition is sinusitis. This refers to the blockage of the nasal sinus by either inflammation or hypertrophy of the mucus. It may affect one or more of the 4 sinuses. So the main causes include the obstruction of the nasal passages by the nasal passages, deflected nasal septum, spurs of the hypertrophied turbinates due to inflammation, the blocked nasal ostia, the exit, that is, results in the accumulation of secretion which provides media for growth of microorganisms. So this results in a secondary infection. Acute sinusity or the acute sinusity results from upper respiratory infection, allergic rhinitis, swimming or dental manipulation, which causes inflammation resulting in increased secretion and block through the drainage. Chronic sinusitis is usually associated with the chronic infection sinus and nasal polyps. Clinical features. There is usually pain over the affected sinus due to inflammatory process and accumulation of pus and absorption of air. Prevalent nasal drainage due to hypersecretion as well. Nasal obstruction due to inflammation can also come or altered anatomy. The turbinate will be edematous, enlarged with tenderness over the affected area, recurrent headache which changes with position. What do we have to investigate for us to confirm our diagnosis? First, we have to have a CT scan which shows sinus filled with fluid or hypertrophied mucosa, a nasal endoscopy to examine or drain the sinus to get the secretions for culture, and sensitivity. When I say we take the secretion for culture, we take them to the lab, use the microscope, we plant them in the media, see what bacteria comes from them. An X-ray of sinus will show fluid in the sinus as well. How do we manage sinusity? Management of the patient's pain related. If the patient is pain related to decrease sinus drainage, inflammation or infection, encourage the patient to take the prescribed medication. Requires antibiotics, for example amoxicillin, to decrease risk of recurrent infection. Expectorant may be used to drain secretion. A steroid like the hydrocortisone relieve inflammation, especially in allergic rhinitis, sinusity. Use the analgesic and decongestant to relieve pain. Instruct the patient to use plenty of fluid to dilute the secretions along good drainage. Nurse patient elevated to facilitate drainage and encourage frequent nose blowing. Nasal irrigation, nasal drops may be used to relieve obstruction or congestion. And the nurse will teach patient to avoid situations which aggravate sinusitis like swimming and diving. Take vital signs and report any increased temperature. If allergies, follow instruction of environmental control by identifying the allergen and avoid stimulation of allergy. Assess the patient for future infection and give appropriate medication. Another thing is peritonsillar abscess. Peritonsillar abscess. Now in peritonsillar abscess develop from the tonsil following tonsillar infection or the pharyngitis, and the tonsils grossly enlarged to sometimes threaten the potency of the airway. The patient will have difficulty in swallowing, dysphagia and the pain, that is odinophagia. The patient presents with a thickened voice, chills, fever, swelling of the soft palate. The management here we have peritonsillar abscess occurs as a complication of tonsillitis and acute pharyngitis, and the tonsils may enlarge to threaten airway passage. High fever, leukocytosis and chills will occur, and the patient needs intravenous antibiotics, incision and drainage for the abscess. Tonsillectomy may be performed after the infection has subsided. When the patient has a mass in the upper airway, patency may be lost. In such a patient, endotracheal intubation may have to be done as well. Airway obstruction. This is the blockage of the airway passage through the airways, that is the nose, pharynx, larynx into the trachea and the lungs. It may be either partial or completely obstruction. The causes of airway obstruction include the laryngeal edema, aspirated food or foreign body, laryngeal tracheal stenosis, that is reduction in the the diameter of the laryngeal and the trachea. Neurological depression, that is the central nervous system is misbehaving due to depression. Tumor as well can cause that one. Clinical features of this obstruction include the stridor, that is sound which is removed, a very rough coarse sound removed during inhalation. Uses of accessory muscle in breathing, substernal and intercostal muscle retraction, wheezing recently, tachycardia and cyanosis as well. Management of this obstruction. This an emergency and intervention are aimed at establishing and maintaining a patent airway, the Heimlich maneuver, the cricothyroidectomy, and the tracheal intubation or tracheostomy and commonly used. So I want to go and check alone and investigate on what we call the Heimlich maneuver, the cricothyroidectomy and the tracheal intubation of the trachea and or the tracheostomy, for you to know if they are being done. Let's start with the intubation. Make sure the patient is well oxygenated, explain the procedure and assemble and check the equipment. Then remove any dentures and administer premedication after intubation. The responsibilities include assessing for correct tube placement, so care for pressure areas and dressing, checking on drainage tubes and use of humidifier. Management should always be part of the post-operative care. Later stomach care, voice rehabilitation and home care are taught to the patient for long-term home management. Disorders of the lower respiratory tract, we have the acute chronic bronchitis, are common condition of the respiratory tract. This is an inflammation of the bronchi. Acute bronchitis is caused by the bacteria and may follow a common cause Streptococcus, Staphylococcus aureus and the influenza, right? The Haemophilus influenza. They are commonly associated with acute bronchitis. So chronic heavy smoking and air pollution contribute to chronic bronchitis as well, and the inflammation of the bronchi brings about the thickening and an increase in mucus secretion, edema, decrease in ciliated cells and narrowing of the bronchi also. So acute bronchitis is commonly a bacterial or what we call infection in a way. So that is that. Very key things to learn on that. So we still have many aspects of our today's knowledge, and there are very many, and you're fighting over to at least understand them. So I was talking about intubation before I went to all this disorder of the lower tract. What again I need you to understand about it? You need to inflate the cuff always after intubing, assess oxygenation and acid-base balance, suction to remove secretion and prevention of accidental disconnection from ventilator blockage, prevention of the over-inflammation of the cuff. Then we have the tracheotomy. That is also mentioned and I never explained. So on the tracheostomy is an incision into the trachea for the purpose of, so you make a hole in the trachea and you incise, unaingiza, so that ukitoboa hapo hivyo hewa itaingia ndani. So it's an incision made on the trachea. The tracheostomy is the surgical creation of an opening into the trachea through the neck. It's used to bypass airway obstruction when somebody is blocked on the obstruction. It also helps facilitate removal of secretion. It also facilitates weaning from a ventilator to permit long-term mechanical ventilation and improve patient comfort. Care of the patient with the tracheostomy involves avoiding dislodgement, assessing the respiratory function, and evaluating the risk of swallowing and speech problem as well. So the patient on long-term tracheostomy should be taught about its care. And the suctioning of the airway for patient with the endotracheal tube or tracheostomy should be done in such a way as to avoid cuff deflation while maintaining good respiratory function. Principles of asepsis must be strictly adhered to. That is, infection causing sepsis. Cancer of the head and neck. That's another thing you need to know. Away from all this. This is also upper respiratory condition. So cancer of the head and neck can greatly affect respiration, and the choice of treatment in cancer of the head and neck is dependent on such factors as extent of the disease, cosmetic and urgency of treatment. However, surgery and radiations are commonly used. Whatever the mode of management, the patient requires health education or radiation, duration of the treatment, change of voice, speech, and emotional adjustment. Nutritional management and improvement of respiratory function are the most important aspects of the concentrated on. In addition to the teaching just mentioned, the post-operative care is done by undertaking the following action. First, putting the patients in a semi-flawless position, clearance of the secretion. Another thing, very important, is care of pressure areas, addressing, checking on the drainage tube, use of a humidifier. Wound management should always be part of the post-operative care. Later stomach care, voice, rehabilitation, and home care are taught to the patient for long-term home management as well. Disorders of the lower respiratory tract. That is now after doing the upper respiratory tract. So disorder of the lower respiratory tract, we shall proceed in the next lecture session. Thanks so much. This is Dr. Uma presenting. Always do not forget to click the subscription button in our YouTube.